ကျွန်တော်အောင်မျိုးထုံးမှာဒီကျွန်တော်မှာပြရတော့ IM2 อ่ะဗောနော် IM2 grad ဒီမှာတော့လဲ pulmonary နဲ့ critical care ICU ကိုကျွန်တော် practice လုပ်ပါတယ်လို့ဒါတော့လဲကိုတီးတလောက်ဟိုကျွန်တော် knowledge တွေနည်းနည်း share လုပ်တာဗောနော်ဟိုဒီကိုမောင်နှမတွေအကိုတွေအမတွေဆရာကျွန်တော်တက်အများကြီးဆရာဆမတွေလည်းပါခြင်းလည်းပါမယ်ပေါ့နော်ဒီထဲမှာဆိုတော့ဟိုမိကုန်းလေးလည်းမေးကြပါကျွန်တော်တက်နေတလောက်လည်းကျွန်တော်ပြောပေးမယ် share လုပ်ပေးတာပေါ့နော်တယောက်နဲ့တယောက်ဒါ knowledge share လုပ်တဲ့ဒီ session seminar လေးလိုပဲပေါ့ဆိုတော့ကျွန်တော် request လုပ်တာက post covid pulmonary complication ဆိုပြီးတော့ဟိုကိုဟိုဒီထဲမှာဗမာပြည်လူတွေပဲလားဒါမှမဟုတ်လို့ရှိရင် audience ကိုနည်းနည်းမိတ်ဆက်ပေးလို့ရမလားဟုတ်ဆိုကိုကပြောတာပြောနေဘလူးနဲ့ဘလူးတွေလဲဆိုတာလည်းသိချမသိတော့ဒါမှမဟုတ်အများကြီးပဲလား
audience ကဆရာဟိုကျွန်တော်ခုနပြောသလိုပေါ့ဆရာဟို NGO က audience တွေကကျွန်တော်တို့ဒီတဝက်လောက်ပါပါတယ်ဆရာပြီးရင်ကျွန်တော်တို့ GP clinic ကကျတော့ဟို GP ထိုင်တဲ့ဆရာမတွေကကျွန်တော်တို့20ဝန်းကျင်ပါမယ်ဆရာနောက် teleconsultation လုပ်နေတဲ့ဆရာမတွေကကျန်တဲ့၄ပုံတပုံလောက်ကကျန် teleconsultation လုပ်နေတဲ့ဆရာမတွေပါပါတယ်ဆရာဟုတ် teleconsultation ဆိုတာဆရာကျွန်တော်တို့ဒီဟို Facebook တို့ကျွန်တော်တို့ Telegram group တွေကနေတဆင့်ကျွန်တော်ဟို voluntarily teleconsultation လုပ်ပေးနေတဲ့ဆရာမတွေပါဆရာဟုတ်ကဲ့ပါ
ဟုတ်ပြီလေအဲ့ဒါဆိုရင်ကျွန်တော်စလိုက်မယ်လားပြီးတော့ဒီကြားထဲမှာဟိုကျွန်တော်ချိုးနေရာမှာ I will take a pause and I will take the questions right ဒီ topic ကအရင်ကတော့နည်းနည်းတော့ cover လုပ်ပြီးသား but I did modify a little bit ဘာကြောင့်လဲဆိုတော့ I think the covid ဒီဟိုကကြာသွားပြီဆိုတော့ဒီ covid အတွက်လည်းနည်းနည်းပြောမယ်ဒါပေမဲ့ in general ဒီ any viral illness နဲ့ဒီ post viral pulmonary complication ဒါမှမဟုတ် covid complication ပေါ့နော်အဲ့ဒီတိုင်းလေးစဉ်းစားရတယ်ပေါ့နော်အကျဉ်းတော့ဒီနေ့ကတော့ပထမဆုံးကဟို recovery မှာ for example post covid complication အနေနဲ့ဘာတွေတွေ့မယ်ဆိုတာကိုနည်းနည်းဦးစားပေးပြောရမယ်ပြီးတော့ဟိုပြီးသလောက်ပေါ့နော်ဟိုမပြီးတော့လဲ day 2ကိုဆက်ပြီးလုပ်ရမယ် day 2မှာ mostly question and answer အဲ့လိုမျိုးဟို informal သဘောမျိုးနဲ့ဟိုအချိန်နိုင်တဲ့လောက်ကိုဖြေပေးရမယ်ပေါ့နော်ဟိုဆိုတော့ဒီ questions တွေကိုကြိုပြီးတော့ post လုပ်နိုင်တော့လဲဟို I can make a few PowerPoint ပေါ့နော်ဒီအခုပြောတဲ့ဟာကအဓိကတော့ for primary care နဲ့ outpatient management ဒီကဦးစားပေးပြီးတော့ audience တွေကိုပြောရမှာပါဟိုတကယ် in depth pulmonary နဲ့ critical care level တော့လဲကျွန်တော်အဲ့လောက်ကြီးတော့လဲကျွန်တော်မပြောရတော့ဘူးပေါ့နော်ဘာလို့ဆိုတော့ scope of ဟိုကနည်းနည်းကျယ်လို့ပါအဲ့တော့ဟိုဆိုတော့ now အခုကဟိုကျွန်တော်သိသလောက်တော့ covid ရဒီမှာလဲကြာလာပါပြီဟိုမှာလဲဟိုတက်နေတော့တော့နဲဝါပြီဆိုတော့ဒီ covid တွေကြာသွားတဲ့အချိန်ခါမှာဒီ acute illness တွေကြာသွားလို့ရှိရင်ကိုကအခုစပြီးတော့ post covid illness တွေနဲ့ဒီလောက်တဲ့ခါမှာ common ဖြစ်တဲ့ condition လေးတွေကိုကျွန်တော်နည်းနည်း cover လုပ်ပါမယ်အကုန်လုံးတော့မဟုတ်ဘူးပေါ့နော်ဆိုတော့ဟို as you ဆိုတော့အဲ့တော့ post covid မှာအဓိကဟလာတချို့လဲဆေးရုံတက်ရတယ်တချို့ကလည်းဒီ home မှာပဲ treatment ယူရင်းနဲ့ oxygen ယူနဲ့ပြန်ကောင်းသွားတဲ့လူလည်းအများကြီးပါအဲ့တော့ဟိုဒီ common symptom တွေကအဲ့ဒီမှာတွေ့တဲ့ဟိုပါပေါ့နော် most common တော့ fatigue ပေါ့နော်ဟို fatigue dyspnea ရှိမယ် cough chronic pain ဟုတ်လားပြီးတော့ဟို insomnia and the ဟိုပါပေါ့ဒီ headache and loss of taste and smell issue ပေါ့နော် you see the percentage in different way ပေါ့အဲ့တော့ so တချို့ကလည်းဒီ hospital discharge မှာဆက်ပြီးတော့ဖြစ်နေတဲ့ symptom တွေပေါ့နော်တချို့ကလည်းဒီ outpatient manage လုပ်ပြီးတော့ဒီ residual fatigue dyspnea cough တွေကိုကျန်တာပေါ့ဒီပထမဆုံး before we cover ဟိုပါပေါ့ post covid complication တွေမပြောခင်မှာ general idea of how virus ဒီ coronavirus က respiratory system, how does it affect? So it affect effect on the airway. It's similar to any other virus. So it can cause inflammatory changes in the airway. So I separate those effects into two. One is on the airway, one is on the lungs parenchyma itself. So effect on the airway about it causes inflammatory changes. It could be transient, or it could be persistent, or it could become chronic inflammatory state, which it will behave like asthma, or reactive airway disease. The effect on the lung parenchyma in an acute setting, the virus can cause pneumonia, acute lung injury, and when it happens, patient end up in the hospital, require a lot of oxygen, and sometimes end up in the intensive care unit. So the outcome is some patient has complete resolution from that pneumonia. So it may take a few weeks or longer. And unfortunately, patients they die from the COVID pneumonia. Those who recover may have residual the lung changes or parenchyma changes, inflammatory changes that continue for quite some time. So how long would it take to recover? So it may be a few weeks or a few months or longer. And some patients, they never really recover. They don't recover totally back to normal. So what they have is they have scarring, they have fibrosis, and they started behaving like someone who has chronic interstitial lung disease, such as pulmonary fibrosis. That's a very small number of patients that could end up chronic interstitial lung disease. The virus also has effect on the pulmonary blood vessel. As you all know, it can cause PE, blood clot, pulmonary embolism, and so on and so forth. So, post-COVID pulmonary complaint. So I divided into the two things, right? One is complaint. Complaint is what patient reports. Patient can report cough, wheezing, shortness of breath, fatigue, or chest pain or chest tightness, or some pleural pain. So these are quite most of the common the complaint patient will tell you, right? And post-COVID pulmonary condition. So this is what we discover, right? So the first one is what patient complaint. We call it subjective complaint. And this is a condition that patient end up into. So one is deconditioning, right? So even if patient recover, a lot of patients they were bedbound when they were very sick. So when they recover, they lost a lot of muscles and they become deconditioned, severely deconditioned, or when they're trying to get up and walk around, they are short of breath. There are conditions associated with airway related. So I separate it in this way so it's easier to understand. All right, so COVID could affect the airway or parenchymal disease, right? So airway related disease patient can have from the COVID. Someone who never had respiratory diagnoses, they can become asthmatic, right? So we can say new onset asthma. Or if they have an asthma, asthma become worse than before. So they have and control asthma. Another one is called bronchiectasis. That's a condition of chronic the airway destruction and dilatation. That's a condition. They can have bronchiectasis, and they can have bacterial pneumonia because their lungs are damaged, and we call it structurally damaged, so that the bacteria become colonized in their airways, and they can have superimposed bacterial pneumonia. A lot of them, as you see in the previous slide, complain of cough after contracting COVID. That could be a few weeks to a few months from the initial diagnosis. So I put it post-COVID cough. So that's how they could present from the airway-related condition. The other presentation is because of pneumonia and damage to the lung itself, they can have interstitial lung disease, such as a lot of scarring. We call it fibrotic lung disease, or some of them may have persistent ground glass opacities, meaning that this is a diagnosis you can only say it when you obtain the CAT scan of the chest. Chest X-ray is not able to provide this ground glass opacity because you can't really say much from the chest X-ray. NSIP means that's abbreviation for non-specific interstitial pneumonitis or interstitial pneumonia. Or you can have, again, the infection in the lungs, lung abscess, pneumonia, superimposed, you can have those. Right. So I put this slide for you to be very clear about what patient will complain, right? So I repeat it again, cough, patient will complain those, right? Cough, or I'm coughing, I have been wheezy, I'm short of breath. But Malabio, know who, well, or I guess I'll keep saying like this, right? Fatigue, chest tightness, chest pain, or I have pleuritic pain, which is when you take a deep breath, it hurt, right? Where over the ribs. That's a pleuritic chest pain. And so when you have those complaints, you need to the match with what is the underlying problem or diagnosis. So the symptom and the diagnosis. So, you know, when someone say, okay, I'm short of breath. So, you know, this is for example, right? So you have to think why this patient is short of breath. So these are the conditions. On the right-hand side, you have a condition, as I mentioned before. So you have to match it, right? So when someone is short of breath after COVID, is it because their condition, or is it because they really have a problem, meaning that they become asthmatic, or they have or truly have a lung disease, or you know, on the right side. So these are the possible differential diagnoses for the complaint on the left-hand columns. So just to get idea of how to think when someone presented with the complaint. So when you have one patient complain one of those symptoms, and you think about differential diagnosis, and how do you work it out, right? So below investigate but test it or right? So first thing out of history, always get a good history is very important, and that will give you a lot of information of what could be, right? And here are we consider the common workup. So baseline is at least you should consider chest X-ray, right? Or if you know you have ability to order CT scan when appropriate, you can order CT scan. And basic labs. Basic lab means you want to look at the renal function, CBC, LFT, things like that. I see a lot of people, not necessarily Burma people, no, or anywhere, okay, what is the role of D-dimer, right? D-dimer order like 30 days after the COVID. Is it, useful? Is it necessary? What is the use of it? So that's the these are the valid questions you should answer before you order a test, right? D-dimer, or CRP. What do we do? How do we use this, right? So you can check the so what's the patient oxygen saturation when patient presented with shortness of breath? Is patient hypoxic or normal oxygen saturation, right? And if patient is coughing up yellow flames and never had it before, and you will consider, well, could it be infection, right? Started with COVID, but now patient have bacterial pneumonia. Could it be pneumonia? So if you think it's a pneumonia, you want to know, you don't want to randomly treat with, all the antibiotic. You want to know, it's, a lot of time we give the empiric antibiotics such as azithromycin, doxycycline, or one of the fluoroquinolone, right? Levofloxacin, you can give it. But it's always nice to know if the sputum grow any bacteria, if they do, and what is a resistant pattern? Because a lot of bacteria become resistant if patient received antibiotic previously. So you don't want to randomly give antibiotic that end up being resistant and it doesn't work. So it's if patient has productive sputum, it's reasonable to check for culture and sensitivity. And then if times and or order the pulmonary function test, right? So that will give you information about how patient is behaving, right? When patient is still very sick, pulmonary function test may not be helpful because patient cannot even perform the test well, right? And echocardiogram, right? So echocardiogram is something if you have a suspicion of, well, patient has cardiomyopathy, right? Clinically, if you suspect that, or patient has PE and you want to know whether a patient is, how the heart is handling, right? Whether patient has, right-sided pressure elevated, how is the intraventricular septum, is it deviated or straight, and things like, there's a lot of information that you can get from echocardiogram. Well, that's only in an appropriate clinical setting, right? So I would take a little pause and see if I should continue like that, or a few questions from the audience before we get to specific topic, right? Because I gonna next topic will be I'm gonna move on to the shortness of breath on the next topic. So let me take a pause and take some comment questions before we jam. People, guys have a time to digest a little bit.
တချို့ဆရာမတွေ chat box မှာမေးထားတာလေးတော့တစ်ခုနှစ်ခုစတက်လာပါတယ်ဆရာဟုတ်ကဲ့ပါဆရာဆရာတွေ့ရမယ်ကျွန်တော်ကြည့်လိုက်မယ်လားเนาะ
D-dimer CRP necessary in management of COVID. The D-dimer and CRP tend to it is helpful in an acute COVID infection. The point is when you have a D-dimer normal versus 10 to 20 times higher in someone with the acute COVID infection, right? So then that makes you think that, well, this is more than just a regular COVID virus. This patient is, if you have a 20 times higher D-dimer and CRP is like over, like the same thing, 10 to 20 times, then you gonna anticipate that this patient could get really sick, right? So most of the patients who got COVID, they do recover without any treatment, right? And as an outpatient. But again, someone who is, somewhat sick, high fever, little, not that shortness of breath, but D dimers is really high, that I would say, the CRP high, and I would say this patient should be observed very closely, because this patient might need some at least prophylactic dose of the anticoagulation, and high CRP tells you that there is an ongoing active inflammation in the lung, that this patient might get worse. So that's kind of guide you to anticipate the probable, course of the infection for that particular patient. Okay. I see that next question is, so when do you do a CT? If you want to diagnose the fibrosis or fibrotic lung disease, do you need a CT scan? The fibrosis is mostly diagnosed only from the CT scan. That's correct. Do you need an IV contrast? No, you don't. You can do non-contrast CT scan of the chest that will give you patient has fibrosis or not. Do you always necessary to do a CT scan to diagnose fibrosis? Well, confirmation of fibrosis is only from the CT scan, but you can have indirect finding on the chest X-ray to suspect fibrosis. But again, the question is, let's say you confirm the fibrosis on a CT scan. What do you do then? What's the next? Do we have a better treatment for pulmonary fibrosis? Even if fibrosis, there's not really any treatment. Okay, there's no role of steroid. It is a scarring, and it's an information only, right? So it doesn't change how you're gonna treat it. CT is not, I don't always recommend CT because it's not gonna change your treatment. So another question about the chest X-ray and follow-up time interval. The X-ray is if you have a COVID patient with significant hypoxia in the beginning, if you repeat the X-ray, let's say a month from now, you could still see some infiltrate there. But what is important is the clinical improvement, right? So if patient require 5 to 10 liter when, first 2-3 weeks of COVID infection, and then 6 weeks later, patient slowly recovering, and oxygen doesn't require any more oxygen. So would you repeat the X-ray, right? Well, the statement is patient is clinically better from 4 to 5 liter oxygen to off oxygen. Would X-ray gonna help you in which way, right? So even if you see the X-ray, you see the infiltrate on the X-ray, when patient is clinically better, you will continue to observe. So X-ray is not really helping, but again, usually it's recommended to look for, especially when patient is not better, because you want to suspect that, well, is there something else going on, right? So secondary infection ရှိနေလား ဟလာ different ဘာတွေတွေ့နေလဲ pleural effusion တွေ့နေလား what is the new finding ဘာကြောင့် patient မတက်တာလဲ so those tests are mostly helpful if patient is not on the right track. Next question, benefit of pirfenidone. So pirfenidone is approved for idiopathic interstitial pulmonary fibrosis. It is not not really approved for the COVID-related pulmonary fibrosis. But even though it's saying that there is no guideline on how we're going to treat post-COVID fibrosis, but there are ongoing study trying the anti-fibrotic agent hoping that whether we're going to see the improvement or slow down the fibrotic process from the COVID. So I would say you could try pirfenidone for well-established diagnosis of fibrosis. That will be out of the standard of care, okay? But again, the concept is you want to try antifibrotic, you could. Would it benefit? We don't know. Another question is when would you start prophylactic anticoagulation? So prophylactic anticoagulation is someone who has severe COVID infection. Severe means number one, they have to be hypoxic. Number two, they have to be when someone is sick enough that their oxygen levels are dropping and they require 2-3 liters at least. That means usually they should be observed in the hospital, but if that doesn't happen as an outpatient and patient mostly in bed, those patients should be on prophylactic anticoagulation, not therapeutic. It's just prophylactic anticoagulation. Do you need prophylactic anticoagulation for someone who recover? No. We like them to get out of bed, at least sit, ambulate, increase their activity. They do not need, once they're back on your feet, they do not need prophylactic anticoagulation, right? So I think I answered most of the questions. So should I move on to the next topic? General Biora, is it too fast or should I slow down?
I see.
All right, so let me see. Here is I choose that topic in general, right? So approach to post-COVID shortness of breath, dyspnea, right? So I'm sorry. So when you have a patient come to you and say, oh, I had a COVID a month ago, I'm still short of breath. And this is how you're gonna approach that, right? So first question is it, objective or subjective? Okay. So objective means, well, you have an objective abnormality, right? Oxygen saturation drop, patient become tachycardic, even talking, right? Or subjective, meaning that when you check oxygen level, it's normal completely, right? For example, saturation 98% room air, heart, and heart rate is fine, but patient just feels short of breath. So you ask the patient, walk around and still short of breath, but oxygen level doesn't drop. So that means that patients, the pulmonary mechanic, right? Ventilation, oxygenation. So lungs is doing the good job, and this become what patient feels. So this is a subjective complaint. Next step is, well, you want to ask detailed history of how patient got a COVID, how sick patient has been, oxygen, what's the maximum amount of oxygen patient require, end up in the hospital, how many days they're sick. All these detailed history give you a sense of, how bad, the pneumonia is for that patient. And you might want to have a basic tests, right? Chest X-ray, basic blood tests, make sure kidneys are okay, things like that, right? And then after you got the information, you're gonna come up with the differential diagnosis. So remember the slide that initially I gave you, I showed to you, the complaint and the condition, right? So these are the differential. Someone who is a shortness of breath, and you come up with all the differential, maybe more than that, box that I show. And then you need to do a workup to rule in or rule out the differential diagnosis, right? And after you find out what it is, and you have to, the next step is, okay, so let's talk about how we're going to treat it. So that's, I'm going to talk about the treatment later on the other slide. And this is the post-COVID. Let's talk about cough. So I guess this is the most common complaint that we have, right? A lot of patients come to you with, I'm still coughing even 1 month after COVID. And how are you going to approach that, right? Basically, this is a very common topic, and it's kind of, it's not that complicated. So first, I want to tell you about how the cough in general, right? So we need to understand how the cough happens. So this is basically, it's a medical science, medical school, just to recall what we learned before. So we have a receptor, cough receptor, and we have a cough arch pathway. So cough reflex. Why do we cough, right? So because our sensory receptors are stimulated, right? So where do we have this cough sensory receptor? So from the neck, from the ear, all the way to the esophagus and stomach. So that's where we have all the cough receptor, right? So we have cough receptor in the larynx. We have ear canal, trachea, bronchi, in the lungs, right? We have not in the parenchyma, only in the pleura. So you have pleura, pericardium, diaphragm, they all have receptors, as well as the esophagus and in the stomach. So that's if those receptors are active stimulated, then the vagus nerve take that stimulus back to the cough center in the brain, which has a cortical control, right? So because that way you can control your cough to some degree, right? And then from that, the center in the brain, medulla, the efferent nerve sent back down to the pharyngeal nerve that supplying the diaphragm, and vagus nerve, back to that's a efferent nerve, okay, and come back to respiratory tract, respiratory muscle, and that's how the cough arch complete. All right. So post-COVID cough is mostly due to the involvement of either the airway or the parenchyma, right? So and you can have transient or persistent inflammatory changes. And the mechanism of the inflammation is what we suspect is neuroinflammatory response. Involvement of the sensory neurons of the vagus nerve. And like I said, that stimulate the whole cough arch pathway. So when you have a patient with post-COVID cough, so you like to ask yourself, after you did all the detailed history, is it the airway related, right? So patient is wheezing, patient is coughing, but oxygen levels are okay. X-ray doesn't show much of an infiltrate, X-ray is clear, but patient is just coughing. So that is most likely the airway related, right? Or is it parenchyma related, which is you can have abnormal chest X-ray, because that's when you see the abnormal chest X-ray with infiltrate or scarring or lines, and that's if you see that, then you started thinking, okay, patient has a lot of scarring, or it's behaving like interstitial lung disease, right? or you see the cavitary lesions, consolidations, or there is an infiltrate, right? So that's where the imaging, become helpful to narrow down the differential diagnosis. So after you narrow down the differential, and that's where you consider, okay, let's plan to how to treat your cough. Okay. Regardless of, whatever reason the cough is, if the cough is so bad, then patients say, oh, I can't even sleep, right? I cough nonstop. So in some cases, you might want to use a cough suppressant. And based on what you find, if you think it's the reactive airway disease or asthma, then you're going to treat it as such, right? So using bronchodilator, you can use the steroid, either inhaled corticosteroid, or sometimes we do systemic steroid for a week, and then you can taper off. Or if patient has abnormal X-ray and a lot of scarring on chest X-ray, and patient is coughing, then you can say, well, it looks like you have a significant scarring, and that is most likely the source of your cough. And so we have to give more time, but we cannot guarantee that the cough gonna go away. But there's but we have to see. And some patient has cough, but all the tests come back normal. Chest X-ray is clean, patient is not wheezing. They just cough once in a while, a month or two after the COVID, and saturation is normal. You did a workup for your heart, everything looks good. And what do you do in those cases? Well, you can say, well, look like the COVID caused inflammatory changes in your airway and all those receptors that will take time to go back to normal. But again, we don't know whether that will happen for sure, but mostly it's gonna go back to normal, but it will take time. So you need to reassure patient. But really, the real treatment, can we get rid of the cough? Not really. We can control it. At this point, the message to ourselves is that we don't know the optimal management. So as of right now, what we're looking at in future for those patients who has the post-COVID cough, not from the scarring, just from the airway inflammation, is we're thinking down the line, maybe, if we can modify the sensory receptor, right? So we call it neuromodulators or anti-inflammatory, different type of anti-inflammatory drugs. These are still under trial, and we're still looking at it. So we will know more about it in a year or two down the line. But again, the post-COVID cough is treated not as different than any other post-viral cough at this point. Okay. I'd like to give you a few the treatment in bullet points. So this is more of a get to the point of to help your practice. If you think patient has scarring, fibrotic lung disease, and the infiltrates are better, and the treatment really is, what do we do about it? Oxygen, exercise, give more time. Steroids are not really helpful for scarring. We don't do that, but some people consider it. If patient has bacterial pneumonia, well, you got to treat the bug, and you better know what you're treating. Culture and sensitivity, you need to do that. Or if patient behave like new onset reactive airway disease, and So you're going to treat with the short-acting beta agonist like albuterol, or you're going to add corticosteroid in an inhaled corticosteroid. Or patient just decondition and short of breath without objective abnormality, then you probably do reassurance, right? And there is a big category of everyone knows about, long haul syndrome, which many patients belong to, and they come to you with so many complaints of fatigue, inability to sleep, and cannot focus, memory loss. What do we do? So, okay. So, this is going to be a very difficult diagnosis and problem. But again, with all the symptoms and everything, for all of them, one thing that you have to recommend, and they all should do, is that they have to exercise. Okay, so they have to exercise. Exercise helps a lot, to the body. And one of the slides I want to show you is you see the post-COVID the symptoms. This is just a rough guide of what could happen in different organ and system from the COVID. When you look at here on the left-hand column, this is a symptom that patient will complain to you, and their benefit of exercise on the right-hand column that you can achieve. So at least exercise is very safe. Even on patient on oxygen, they should exercise with the oxygen on as much as they tolerate it. They don't have to overdo it, right? We recommend it. So I want to share a few image slides with you. This is a CT scan of a post-COVID patient where you see that the airways are dilated and you see a lot of lines, and so do you see my cursor moving?
Yes, yeah.
So this is an airway. This is a right upper lobe airway. It's got dilated, it's pulled apart. So there you got some bronchiectasis, and then a lot of lines and pleural base. So these are scarring, and you see that on both lungs, right? So that's a post-COVID mild bronchiectasis and scarring. And this is a picture of what we call a ground glass. This patient could be in an acute COVID or even during the phase of recovery. So this is what the ground glass looked like on a. All right, so this is a normal chest X-ray on the slide A, but you see the small area of ground glass on the left upper lobe, and then when you look at on the right-hand side, you see the subpleural ground glass here. And on the bottom, this is a post-COVID, a lot of lines and little holes at the dependent portion of the lung. On the right side, this is the right lower lobe, and you see that on the left side as well. These are called the subpleural fibrosis, and they're little honeycomby in there. Okay, so there are other conditions that I want to just put a few slides in here, tell you COVID can cause COPD exacerbation. I cover asthma, bronchiectasis, interstitial lung disease as far as the parenchymal disease is concerned, and then organizing pneumonia. That's another the entity that it's a non-infectious pneumonia caused by prior viral illness. And then you can have PE and pulmonary hypertension. All right, so general treatment for primary care and outside set. So how you gonna, this is just a gist and the bullet point to take home. If you have a patient with predominant airway disease, well, that includes COPD, asthma exacerbation, or even bronchiectasis. You can, and bronchodilator and steroid, that's the key. You have, if you diagnose, you think or you suspect interstitial lung disease or organizing pneumonia, I will leave that to specialist referral. Can you treat by yourself in where you are in the remote area? Well, there's, I would say, first of all, the treatment is very, it's not going to fit, it's not going to benefit that much to the patient. It probably causes more harm to the patient by putting different medication that you think it's going to help. But again, those cases, I would recommend defer to a specialist. And then same thing with pulmonary hypertensions and PE, at least you can throw in the anticoagulation. The question is how long you're gonna treat it, what is the goal, which agent you can, when would you stop? All these questions are need to be answered because the anticoagulation is not without risk. It has a risk. Patient hit with something and fell, and it could, patient can have bleed in the brain. So it's dangerous. So unless the benefit is clearly demonstrated, you should not be easily jammed on treatment. If you're not sure about PE, then I wouldn't treat it. I'm gonna stop here. We are 5 minutes away from completion, and I'll take questions, and then I have a few things to talk about tomorrow. We can prepare. What I prepare for tomorrow is I'm gonna cover briefly about ARDS. If you guys have some questions, just to touch base. I don't want to go in depth, and I will cover asthma just in general, because you're gonna, even though this is COVID time, but you might want to know or have question about just to refresh your memory and knowledge about the asthma update. Okay, I'll take a pause and then take a questions.
ဆရာကျွန်တော်တို့ chat box မှာမေးခွန်းလေးတစ်ခုတော့ရောက်နေပါတယ်ဆရာဟုတ်
ကျွန်တော်ဖတ်ကြည့်လိုက်မယ်နော်
ဟုတ်ကျေးဇူးပါဆရာ
So patient is on 3-liter oxygen for 3 months after COVID. Without oxygen, saturation dropped to 88 to 91. So this patient, without oxygen, saturation dropped between 88 and 91. So the minimum amount of oxygen saturation we have to maintain is in anybody is above 88%. Okay, so if this patient is able to maintain 88 and above, that should be enough without oxygen. But here's the question. The question really is saturation 88 to 91 at rest, or even with exertion activities? Patient walk for like 100 feet and still oxygen saturation maintain above 88%. If that is the case, this patient doesn't need it. But there are other things that you have to consider, right? Because is patient, or is it 40 years old with previously healthy with no lung problem, or is it 80 years old with previously smoked or previous chronic lung disease or TB or other conditions? So what is, so they're gonna give us a lot of information who you're gonna think, okay, this is acceptable and this is normal. because 40 years old with no prior lung disease, and if I see that, okay, saturation, 88% room air, 3 months later. So that means without X-ray, I can tell that, well, this patient has significant damage in the lung from the COVID, right? Even though he recovered some, somewhat, he's still disabled quite a bit from this. What else? On exertion, if this is patient 88 to 90% on exertion, that's pretty good. So I would say though, without oxygen saturation drop. So 88 to 91, I would say this is still acceptable. I'm okay. So I would say, hey, you're better. Let's wait. Let's push yourself. You can be better. So give more time. I would say that. Does awake prone still benefit post-COVID condition? The answer is no. So once patient recover, well, proning, okay, so let's clarify the proning a little bit, right? Proning, the basic, so proning is, proning improve dependent atelectasis, meaning that when you're lying flat for quite a long time, part of your lung in the dependent portion to the back, right? Lungs are, they become atelectatic, and that doesn't participate in gas exchange. So by proning, by supine and proning, you improve that atelectasis and improve oxygenation. So that's what it is. It doesn't do anything else, right? So once patient recover, you don't need it because patient is not in bed anymore. Patient should not be in bed most of the time. Next question is, do we give steroid to post-COVID cough? Well, post-COVID cough, most common reasons, if it is not scarring, is like any other post-viral bronchitis. What do? Viral bronchitis cause vascular, the airway inflammation. So you could try the steroid, inhaled steroid. There's no preference on which steroid you should use, as long as they are inhaled corticosteroid, and you can see they help or not. So usually, within a 4 to 6 week timeline, you should see the difference. If patient doesn't feel any benefit, you better stop it because it doesn't work anymore. The benefit of the neck and acetylcysteine, the inhalation, there's no benefit. Can we use it? Sure. It doesn't really hurt, but it doesn't, make it better. I think I answered all the questions.
Oh, Sarah Shamaro Nelly, who Megon Lady Shin, Shao, Amulo Vidaya Milea or Akina, or Yayama, a similar
Yeah, put be like
okay,
how long should we wait to give vaccination? Just recover. What is a lung complication? I would say how long do we? That's I don't want to just guess, but usually they ask for about 30 days or so to wait to get vaccinated again. But even if they don't get vaccinated, that innate immunity, natural immunity from the COVID infection, they last for quite a long time. So I'm not in a rush to give a vaccination, but again, it should be considered. Any other questions? Manipandra or anything, any topic? That's all. General Babio topic ခုနကျွန်တော်ပြောသလိုပေါ့မနေ့ဖန်ဟာလေးကတော့ဒီ asthma ကြောင့်နည်းနည်း focus လုပ်သွားမယ်ပြီးတော့ကြားထဲမှာရှိတဲ့ question တွေရှိရင်အဲ့ဒါကိုအဓိကထားပြီးတော့ဖြေသွားပေးမယ်ပေါ့နော်
ဟုတ်ကဲ့ပါဆရာဟုတ်ဆရာတို့ဆရာမတို့ဆရာမတယောက် unmute လုပ်ထားတွေ့ရခင်ဗျဆရာလားဆရာမလားမသိဘူးဟုတ်မေးလို့ရပါတယ်ခင်ဗျဟုတ် sorry ပါ
ဟုတ်ဆရာတခုတော့မေးမယ်နော်ဆရာ Hello
ဟုတ်ကဲ့ကြားပါတယ်ဆရာမေးပါဆရာဟုတ်
ဆရာဟိုလေ anti ဟိုcough sorry cough suppressant မှာလေဆရာတို့ recommendation page နာများရှိတာမပြောဒီမှာကလေ nuclear လို့ခေါ်တဲ့ acetylcysteine သုံးတာများတော့လေဆရာ
ဟိုသုံးလို့ဟိုကျွန်တော်ဟို honestly ကျွန်တော်ကတော့တခါဟိုကျွန်တော်ကတော့ generally ကျွန်တော်မသုံးဘူးဟိုဘယ်လိုခေါ်မလဲဆိုတော့ cough suppressant မေးလို့ရှိရင်ဘာတောက်အောင်လဲဆိုတော့ကျွန်တော်ပြောတယ်ကြိုက်တာတောက်ဟိုသူကပြောတယ်လေဟို would it work ဆိုတော့ I said I don't know လို့ဟိုDM လား cough suppressant က there's so many kinds လေ right ဆိုတော့ဟို does it work ဆိုတော့အဓိကတော့လေသူကဒီ different mechanism နဲ့ cough ကိုပဲ suppress လုပ်တာပဲ right so it's not treating anything about the airway inflammation ကိုလည်း treat လုပ်တာမဟုတ်ဘူးဆိုတော့ဟို cough suppressant ကဟို only if it is very severe unbearable cough ကြမှာပဲစဉ်းစားပေါ့နော်တာမန်ဟာလောက်ကတော့လေဟိုနောက်တစ်ခုကလည်းအမှ steroid try လုပ်မယ်ဆိုလို့ရှိရင်လည်း airway anti inflammatory treatment အနေနဲ့လည်း it may help လေနော်
Okay
Next question, what is a post-COVID oxygen dependent condition? Well, so someone with post-COVID, let's say 3 months and still require oxygen. Oxygen, oxygen saturation drop below 88%. So that means patient has chronic lung disease, right? So if it is like only 2-3 weeks from COVID, so no, I will give him more time for recovery. If it is 3 months and patient still require oxygen, so that means patient recover, patient is better from COVID, but the lung got affected and now not doing the job. You know, so this patient most likely gonna belong to chronic lung disease, and I will at that point I would just do more workup. What else are we missing? Patient has persistent ground glass in the lungs, or it just is scarring, or patient is still in bed and is still not moving around. What else going on, right? Is it PE, pulmonary hypertension, there's or cardiomyopathy? So there are so many other conditions that could be related after COVID. So you need the whole workup at this point. You cannot just say, okay, this is just from COVID. The next question is, should we give the metoprolol or diltiazem? Well, it depends, right? So in an acute, illness, it's because of COVID, acute infection. We don't use the any beta blocker or calcium channel blocker because the body is trying to fight the COVID, right? And you don't want to just block the sympathetic drive unless unless it's become out of control, meaning that the heart rate is like more than 130 all the time. Then you might want to use a small dose of beta blocker. But in general, you don't want to just block the body sympathetic drive when it's fighting it. Post-COVID, which is more so in someone who remained tachycardic during post-COVID. If it is related to activity or exertion, solution or it's expectedly, right? So someone with heart rate of 120 when they're walking fast, but as soon as they sit down, the heart rate drop back to less than 100. That means that's okay. We don't need to treat it. Slowly, but it will improve. But if a lot of the persistent tachycardia over 100, and you might want to make sure that you're not missing any other conditions such as AFib တို့ different ဟာတွေပေါ့နော် if it is a sinus tachycardia and you can try low dose beta or calcium channel blocker it doesn't really hurt
ဟုတ်ခုနဆရာလားဆရာမလားမသိဘူးခင်ဗျတယောက်အန်မြူလုပ်လိုက်တာတွေ့လိုက်ပါခင်ဗျဟုတ်မေးစရာများရှိလို့လားမသိဘူးခင်ဗျမေးလို့ရပါတယ်ဟုတ်ကဲ့ပါ
Hello
ဟုတ်ဆရာမေးပါဆရာ
ပါခင်ဗျာကျွန်တော်ကဒေါက်တာဆွဲပါဦးလမ်းပြကျယ်အဆိုစီရှင်းရပါခင်ဗျာဟုတ်ကျွန်တော်တခုသိချင်တာကြောက်လေpatient အဲ့လိုမျိုး recovery ရသွားပြီပေါ့နော်ဒါပေမဲ့သူအရင်တော့သူ့မှာ underline လည်းမရှိပါဘူးသူ့အသက်ကလည်းလိုမျိုး30-35ဝန်းကျင်ပေါ့နော်သူကကြတော့အဲ့ဒီမှာလေrecovery ရသွားပြီးပြီမဲ့လေoxygen concentration ကကြတော့အရင်တော့လောက်မဖြစ်တော့ဘူးပေါ့နော်အခုတိုင်းကြည့်လိုက်ပြီဆိုလို့ရှိရင်လေ93-94လောက်ပဲဖြစ်နေလို့ဆရာဟုတ်အဲ့မျိုးဆိုလို့ရှိရင်ဘယ်လိုလုပ်ရမလဲမသိဘူးဒီ post covid အဲ့လိုမျိုး screening တို့ဘာလို့လုပ်ဖို့အတွက်ကြောက်လေဒီသူကကြနေပါရောက်နေဆိုတဲ့အခါကျတော့ပေါ့နော်လုပ်ဖို့အဆင်မပြေဘူးဖြစ်နေလို့ဆရာဟုတ်
recovery ဖြစ်နေတယ်ဆိုတာကဘာလဲ shortness of breath with exertion တောင်တိတ်မရှိတော့ဘူးဟုတ်လား
ဟုတ်တယ်ဆရာဟုတ်အဲ့လိုမျိုးဒါပေမဲ့အဲ့လိုမျိုးအပြင်းထန်နေတော့အဲ့လိုမျိုးလုံးလို့မရသေးဘူးပေါ့နော်ဆရာလမ်းတွေပါရှောက်လို့ရတယ်ကားတွေပါမောင်းလို့ရတယ်ဒါပေမဲ့လိုမျိုးကြီး oxygen concentrate သူကအဲ့အောင်စိတ်ရောက်နေလားမသိဘူးပေါ့နော်အမြဲတမ်းသူတိုင်းကြည့်နေတိုင်းကြည့်လိုက်လို့ရှိရင်လည်းအမြဲတမ်း93-94ပေါ့နော်အဲ့လိုမျိုးပဲဖြစ်နေတာပေါ့နားပြီးတော့မှတိုင်းလို့ပြောလို့ရှိရင်လည်းသူကအဲ့တိုင်းပဲဖြစ်နေလို့ဆရာဟုတ်ခါလေးတိုင်း92လောက်ဖြစ်တယ်လို့ပြောဟုတ်
ဒီ symptom မရှိဘူးဆိုလို့ရှိရင်တော့ဘာမှ reassurance ပဲလုပ်လိုက်ပါဘာလို့လဲဆိုတော့အသက်လည်းငယ်တယ်ဒါဘယ်လောက်ရှိပြီလဲ post covid time မှာ
35ဝန်းကျင်လောက်ပါပဲဆရာ
ဟုတ်အချိန်က duration က3 months လား2 months after covid လား
လောက်ရှိပြီတစ်လခွဲလောက်ရှိပါပြီဆရာဟုတ်
ကျွန်တော်ပြောရမယ်တချို့လဲ6 months လောက်တဲ့အထိကောင်း recover မရှိတဲ့လူတွေလည်းရှိတယ်လေဆိုတော့good အဲ့ဒါpatient ကိုတော့ good news ပဲပေးလိုက်ပေါ့နော်good news is you don't even patient oxygen တော့မလိုတော့ဘူးဆိုတော့ဒါ this is a good news လေ93-94 is it normal ဆိုတော့ well you can say it's normal and expected သိရမလားတိတ်တော့မပူပါနဲ့ဒီခုပဲပြောမှာအသက်လည်းငယ်တယ်ဆိုတော့တဖြည်းဖြည်းနဲ့ push လုပ်ပါဟလား healthy diet weight gain မဖြစ်စေနဲ့သိရမလားexercise စားမှန်နဲ့ဒီ healthy diet စာ weight gain မဖြစ်စေနဲ့ exercise ကိုတဖြည်းဖြည်းနဲ့ advance လုပ်ပြီး introduce လုပ်ပြီးတော့တိုးပြီးတော့လုပ်ပေးပါအဲ့နည်းနဲ့ပို့ပြီးတော့ကောင်းလာပါလိမ့်မယ်လို့ပဲပြောလိုက်ပေါ့သိရမလား
ဟုတ်ကဲ့ပါဟုတ်ကျေးဇူးတင်ပါတယ်ဆရာဟုတ်
chat box မှာလည်းထပ်မတွေ့တော့ဘူးဆရာမတို့ unmute လုပ်ပြီးလည်းမမေးတော့ဘူးဆိုတော့ဒီနေ့ဖို့တော့မရှိတော့ဘူးနဲ့တူတယ်ခင်ဗျဟုတ်ပြီးတော့ကျွန်တော်တို့မနက်ဖြန် session လဲဟုတ်ဆရာတယောက်မေးထားပါသေးတယ်ဆရာ question လေးတစ်ခု chat box မှာပါဆရာဟုတ်
continuous protective cough for antibiotic. So first thing I would do an X-ray and I would do if patient has no fever, it's just a cough and it's clear, I wouldn't treat it. You know that there's a mucus protection, airway inflammation. It's quite common. So it could be one of those where patient behaving like, could it be a bronchitis nature with making mucus? But if patient sputum characteristic is, let's say, yellow and thick, or foul smelling pillow sheen, the tree load or reasonable pit upon, or other mu solution or or previous antibiotic dabu solution or the bamacachamolobene, azithromycin, or nene to get doxycycline or azithromycin ကို7 day လောက်ပေးလိုက်တာက reasonable ဖြစ်တယ်အရင်ဒီ covid ဖြစ်တော့ different antibiotic တွေအများကြီးရတာပူးတယ်ဆိုလို့ရှိရင်တော့ recommend doing the culture first before antibiotic မပေးခင်မှာဘာလို့လဲဆိုတော့ဒီ patient ကဒီ drug resistant ဒီ pathogen ရှိဖို့ chance ကများသွားပြီ right ဘာကြောင့်လဲ previous antibiotic ရဘူးလို့fever တွေဘာတွေအရင်ကြီး sick မဖြစ်တဲ့အတွက်ကြောင့်မို့လို့လောစရာလည်းမလိုဘူးဒါကြောင့်မို့လို့အဲ့ဒီ culture data ရပြီးတော့မှပဲ antibiotic choice ကိုစဉ်းစားဖို့ recommend လုပ်တယ်ပေါ့နော်
ကဲပါဆရာတို့ဆရာမတို့ဟုတ်ဆရာမတို့ဆရာတို့မေကွန်းလေးတွေမရှိတော့ဘူးထင်တယ်နော်ဟိုတော်တော်များများလည်းမေးပြီးသွားပြီဆိုတော့မနက်ဖြန်လည်းဆရာဆက်ရှင်ရှိသေးရဆိုတော့ဟုတ်ဆရာမမေးစရာရှိသေးလို့လားမသိဘူးမေးပါခင်ဗျဟုတ်အမြူလုပ်လိုက်တာတွေ့လို့ပါဟုတ်ကျေးဇူးပါဟုတ်မနက်ဖြန်လည်းဆရာဆက်ရှင်ရှိသေးရဆိုတော့လေမနက်ဖြန်ကျမှတချို့မေကွန်းလေးတွေရှိသေးရင်ဆရာတို့ဆရာမတို့ထပ်မေးလို့ရမယ်ထင်ပါတယ်ဟုတ်ဆရာကျေးဇူးအများကြီးတင်ပါတယ်ခင်ဗျာဆရာဗာများပြောချင်ပါသေးလဲခင်ဗျာဒီနေ့ဆက်ရှင်
ဆရာကျွန်တော်ကတော့မနေ့ဖန်ကတိတ်အများကြီး topic တော့မရှိဘူးဟိုကျွန်တော် asthma နဲ့ ARDS ကိုနည်းနည်း cover လုပ်မယ်ကျွန်တော်ပြီးတော့ let me see ကျွန်တော် share မလုပ်ထားဘူးနေတယ်နော်
မလုပ်ထားပါဘူးဆရာဟုတ်ကဲ့
so asthma အကြောင်းကိုကျွန်တော် promise အေးပေါ့နော်ဒီ ARDS နည်းနည်း touch လုပ်ပြီးရင် asthma in general ပေါ့နော်ဘာလို့လဲဆိုတော့ဟို just to refresh ပါပဲတည်ရမှာကိုလည်းပါကြောင်းပြောမှမသိကိုဗစ်ကလည်းပဲဟို post covid မှာထွေထူးလည်းအများကြီးလည်းမရှိဘူးလေဆိုတော့ဟိုကျန်တဲ့အချိန်ကတော့လည်း question and answer ကိုပဲဒီပြောတာပေါ့နော်
ဟုတ်ကဲ့ပါဆရာမဟုတ်ကဲ့ဆရာဟုတ်ဆရာမတွေသိကျင်တာလေး
ဟိုပေါ့မနေ့ကမှမေးသိကျင်တာလေးရှိလဲနည်းနည်းဒီနေ့ကိုနည်းနည်းစဉ်းစားလာလိုက်ပေါ့နော်
ဟုတ်ကဲ့ပါဆရာဟုတ်အဲ့ဒါကျေးဇူးအများကြီးတင်ပါတယ်ဆရာဟုတ်ကဲ့ဒီနေ့ section အတွက်ဟုတ်ဆရာတို့ဆရာမတို့အားလုံးလည်းကျေးဇူးအများကြီးတင်ပါတယ်မနက်ဖြန်မှာပဲကျွန်တော်တို့ဟိုဆရာရဲ့ day 2လေးမနက်ဖြန်မှာထပ်ဆက်ပါမယ်ခင်ဗျာမနက်ဖြန်မနက်8 နာရီမှာကျွန်တော်တို့အားလုံးပြန်ဆုံကြပါမယ်ခင်ဗျာဟုတ်အားလုံးကျေးဇူးပါဆရာတို့ဆရာမတို့ဟုတ်ဆရာလည်းကျေးဇူးအများကြီးတင်ပါတယ်ခင်ဗျာဟုတ်ဆရာ
Thank you ပါ